I am, I believe, right? So I'm actually very pleased to be here. It was relatively short notice, but I hope we can give the best to our capacity. And like you said, actually, I don't have a presentation. I'm a physician and endocrinologist and also a senior instructor at the Aga Khan University Hospital in Nairobi. So I am hoping that this would be more of a discussion, and if Dr. Karen has any presentation, then I think it would be great if we could go through it and then have a discussion. But otherwise, I'm willing to give in the best and simplest way possible the whole concept of menopause and what it means to a woman, not only as a patient but holistically as a human in different spheres of life and the effect it brings in. So I look forward to a very fruitful discussion today. Thank you.
Okay, it's very off the cuff. Is Dr. Kingi around? If you're there, please. Oh, she's joining. Okay, she's joining. Let's give it like 1 minute for Dr. Kingi to join, and I'll put the Facebook link for those who want to follow it on Facebook Live. And Karen and Dr. Sokwala, I also made you co-host, so if you see anyone hanging out there, you can always admit them. Dr. Kingi, have you situated yourself? Oh, she's still joining. Okay, you know what, Karen, because this is heavily on your side, because it's your bread and butter. So could you just kindly tell us what menopause is, and just a definition of what it is, and then we can take it up from there. What is menopause? You need to unmute yourself.
Oh, can you hear me?
Yeah, yes, I can.
Okay, I actually did prepare a small 5-minute presentation, if you allow me, so that I don't forget a few things. And it's basically for the layman generally. Let me say it that way. So don't worry, it's not going to be very classy like class, yeah?
Yes, thank you.
Okay. Okay, can you hear me?
Yes, we can.
Okay. Are you able to view that?
Yes, we can.
Okay, perfect. So I promise you it will be very, very short, but it will be basically for you, and then we can pick it up from there. Okay, so I'll give you what the definition of menopause is. Just give me a second. I hope my charger is not going off. Okay, but I'll try and rush it, okay? So I'll give you a definition, and that is the cessation of periods for more than 12 months. And it's usually as a result of reduction in some hormone called estrogen. And in most of the people, it's usually because of your egg reserve in your ovaries that have reduced. So basically just a period of 12 months without any periods. And this is at the expected age. Usually, menopause starts anytime from 40 years and above, but we usually divide it into 3 different divisions. There's that one who's perimenopausal, that is early, that's early 40s. Menopausal, that is now after 12 months of no period. And then most of all the women will have menopause at the average age of 51 years old. So why do you get it? The part in your brain that tells the ovary to produce estrogen. And that's a hormone that helps you have your period, it controls your ovulation, egg production. And that egg production is what helps you have your normal period every month. That's just as simple as I could put it for you. So it's just a coordination between your brain and your ovary. So most people will go into natural menopause from 45 years and above. And then there's those ones who can go into menopause because of surgery, any chemotherapy, okay, or radiotherapy because of cancers. And then those ones who go into premature menopause, either because of genetics, any autoimmune conditions, and chromosomal abnormalities. They can see the stages of menopause. It just doesn't start immediately. And the message here is that we cannot be able to tell at what point your periods will completely stop. So we are not able to say that you are going to go into menopause at 45 or at 50, okay? So that's just basically what that says. Age of menopause is usually on average 51 years old, and it's usually genetically determined. But if you're a smoker, you're likely to get into menopause even up to 2 years earlier. Triggers can be smoking, ethnicity. We've had different ethnicities go into menopause at different times, and obesity also has a play in that. So most of the generation and the population will have mild to moderate symptoms, but some will get no symptoms at all. So don't be surprised if you don't get any symptoms. And the others ones will have very severe symptoms, and that's around 20%. So now what are the symptoms that everyone wants to understand? Because it's a very gray area, because every woman has to go through it at a certain point in their lives. And these changes usually cause a lot of worry, a lot of anxiety for most women. So there'll be mood changes like depression, anxiety, some memory loss, sore breasts, bloating, irregular periods. And then when you're completely going into the full 12 months of no period, you'll experience things like hot flashes. In fact, this is one of the reasons why people will say that they're going into menopause, because of the hot flashes. It's that feeling of heat coming through your neck to your face, even on the chest, and it takes even up to 4 minutes. And it causes night sweats. You don't sleep very well at night, joint pains, and fatigue and irritability. But now when you're already done with your menopause, when after 12 months of no period, you're going to experience some vaginal dryness. Your libido is going to change a little bit, but it's good to note that for some, the libido might not necessarily reduce completely, but may actually increase. So maybe it's good news for some people. Vaginal itching, pain while having intercourse, that can also occur. As you can see in that picture, I think it's a husband and wife that are there, and the husband is telling the wife, you really need to see a doctor about these hot flashes. The igloo is all melted down. Okay, so main problem maybe might be hot flashes, libido, itch maybe, yeah, but most people will mostly come with the hot flashes. So what to do on your own? To cool yourself, you can use an AC, fans, water sprays, cold drink can really help you. Loose clothing, avoid smoking and caffeine especially. Some kidogo exercise would also be good, not extreme, because again, extreme exercises can give you that you'll experience, this kind of hot flashes because of that exercise. And loads of lubricant, especially the water-based. Some people talk about vegetable oil, egg white. I don't know what you think about it, but you can put it in the comments and tell us what you think. But when do you really need help? By the time anyone goes to the hospital because of these things, it's about hot flashes, very severe cases. So we usually offer relaxation therapy, mindful therapy, cognitive behavioral therapy. I'm sure they'll discuss that in terms of psychiatry. But there's also the hormone therapy, which we'll discuss further in our discussions, that would be important to note that we actually do give, and some other drugs like antidepressants. Natural therapies are also present. We'll talk about them in a few. And some estrogen creams that help in terms of the vaginal dryness. What about cannabis? Tell me what you think in the comments, because as doctors, we are also having a blank page just like that one in terms of cannabis use in menopause. But of course, we've had people complaining of cannabis helping them through this. So I think I've given it in a nutshell. So we can take it up from there, Professor.
Okay, I think that was very comprehensive. So just if I got it right, we experience menopause from between 40 and 51, right? And is that across all ethnicities? Like, will my Caucasian counterparts here experience it at 51 and will my cousin in Namasoli also experience it at the same age, or does it differ across the ethnicities?
It does. It does really differ between ethnicities, and also you can find, in terms of familial, if you really look into, let's say, your mother and your mother's mother, you'll realize that there could be a pattern of when you go into menopause. So if your mom went into menopause, let's say fully at 52 or 55, then you're most likely going to follow the same route. In terms of ethnicity, yes, we've noted that some areas, like let's say, for example, the Caucasians, people from Asia tend to go into menopause a little later than as compared to all the other ethnicities. It's not very clear whether it's about their diet, about whatever they do, but yes, it has shown that ethnicity plays a role in terms of when you go into menopause.
And does the age I start my periods determine when my menopause will start, or that doesn't, menopause doesn't care?
Not necessarily, but it's been noted that a few people who start earlier, even in terms of number of pregnancies, we thought that maybe if you have more children, you go into menopause earlier, but there's no clear exact time, or you cannot predict that you're going to go into menopause earlier or later. It's very dependent on your reserve.
Okay, and I think people need to understand the difference between we females. I have to be careful, I'm in the States, so yeah, we people born with ovaries and people born without ovaries, because the eggs you have are determined at birth. You don't get any more. Like, there's no more production. Once the reserve, it's like a piggy bank. Once you empty that reserve, you're done. But unlike spermatogenesis, or this is why we need to tone it down. Unlike the production of sperms, which continues till late, and that's why we have the saying pakamze kunywa maziwa, that continues on and on and on, and that's why we have menopause. So, if we are looking at the etymology or the root word menopause, where does it come, and why don't we call periods menostart then?
Actually, the periods, when they're starting, they have a name. They're called menake. Those are usually hospital-related jargon that we use. But yes, when we were born, as females, once you're born with all the eggs you need in your lifetime during your reproductive age group. In fact, you're born with like around 450,000 to 500,000 eggs. Which again, I don't think we will all get 500,000 children, but every month we really do produce, at a certain point, from when you go into your puberty, you start producing an egg each month. And that is when your period begins. In fact, it's important for you to understand that an egg is most of the time when you produce an egg, it will be followed by a period. If you produce an egg, it will be followed by a period. So that is why we're able to recognize when you go into menopause, because if you miss your period for a whole year, it means then your eggs have reduced. And again, the ones that are present, you see the ovary always produces an egg, and you say they have so many eggs, you couldn't have produced all 500,000 of them during your lifetime. But at the end, when you're going into menopause, what happens is that you have your hormones, which I have just discussed about, the estrogen, which is the most important at this point. It's the one that causes those eggs to there's a hormone called FSH. Maybe it's not very important for most of the people, but it causes eggs to start maturing. And those maturing eggs, as they mature, that egg that is it's called the dominant follicle, starts to produce estrogen. Okay, so when it produces that estrogen, and then there are other hormones involved, that egg is produced and it's released. So when you're going into menopause, what happens is that your estrogen levels start to dwindle a bit during perimenopausal state. I mentioned there's a state where you still have your periods, it might be irregular, they start being irregular before they completely go. That's the perimenopausal state. Estrogen keeps going up and down, up and down. Even if we do any test at this point, we're not able to tell whether that, I'm going to put my phone on the charger, sorry about that. We're not able to tell exactly at what point your estrogen starts to deplete completely. So what happens in this situation, there's that hormone called FSH. It starts to increase once the estrogen starts to decrease. So that FSH, as it is increasing, those remaining eggs, because they're being hypersensitized, they were responding to FSH, but now they're not responding. So that's what happens when there's high FSH, low estrogen levels. Now you completely stop having your periods. So yes, that's what usually happens. It's not that all the eggs completely go away, but the ones that are remaining are not able to respond to the normal hormones, which lead you to have your normal cycle. I hope I answered that question.
Okay, so let me bring in Dr. Sokwala for a bit. So what's your role in managing menopause? I know it's heavily on the obstetricians and the gynecologists in the whole world, really. So what's the role of other physicians and endocrinologists in terms of management of menopause?
Yeah, thank you for that question. What I'd like to tell you is we are the highest contributors to the gynae clinics when it comes to management of menopause, because especially as endocrinologists, we see a lot of patients who are at high cardiovascular risk. For example, diabetes, patients with diabetes, majority of our patients are usually with type 2 diabetes, and that affects majorly patients at the upper age limits. So we see a lot of females in that age category where now they are approaching menopause, they are perimenopausal and also going to menopause and have the effects of menopause. And beyond that, I mean, it's not only that we refer those patients to them and we work closely with the gynecologist, but basically the point is that the whole aspect of menopause has a huge association with cardiovascular risk. That means issues related to the heart and the blood vessels. And there's also an association, especially for patients, when you want to consider starting them on treatment, especially with hormonal therapy or even non-hormonal therapies, which are not necessarily like constituting hormones, which I think we are going to discuss the hormonal and the non-hormonal bit. But at that point also is when we do risk assessment heavily, because even those drugs are associated with increasing your risk, for example, of clot formation, your risk of cardiovascular diseases. So for example, especially patients who have got, and also osteoporosis, sorry. So like menopause itself has an increased risk of osteoporosis. At what point to handle that as well as an endocrinologist, that role heavily lands on us as well to assess risk for osteoporosis, risk for fractures, how to manage those fractures. So what I feel is handling patients with menopause, and especially the menopausal symptoms, the vasomotor flashes, and other risks that are, complications associated with low estrogen levels, needs a multidisciplinary approach. So that's why we are all three of us here. So the gynecologist is very key in this role. The endocrinologist, very key because of assessing which patients are fit for which kind of hormonal therapy as a holistic assessment, and the psychiatrist, because menopause has a very huge association with psychosocial issues and, otherwise related to like the whole, like I told you even in the beginning, it's the whole lifestyle of a female which is affected with these issues that come in with menopause. So definitely we do have a role to play there.
Okay, so in terms, and Karen, let's go back to you. In terms of the other symptoms that we see, and Sokwala has touched on them, I know most people just think of hot flashes and end of the periods. So my two questions are, if you lose your uterus before the age of 40, how do you tell you have menopause? And the other thing is, what are the other major symptoms we see out there in the clinic besides hot flashes that will let someone know that they're either pre peri or menopausal.
Okay, thank you very much. You have touched on a very important question because as you can see, we diagnose menopause, even personally, even individuals can diagnose menopause on their own at home by just looking at how long their periods have missed, that is 12 months. But of course, we have those ones who undergo hysterectomy, which is a removal of the uterus earlier than that time. So it would be a little difficult to be able to tell that you're having you did not have your periods because you've just stopped having all your periods since you had your uterus removed. But most of the time, you will be able to tell if the ovaries are still present, because there are different types of hysterectomies that are done where you remove the uterus only and leave the ovaries. So it means you will still have the protection of, as we usually say, estrogen is protective for females. You'll still have that, you'll be fine. But once the estrogen starts to deplete, you start having those symptoms of the hot flashes and the rest, which I will discuss in a few. So yes, they can be able to tell because they will start experiencing some of these symptoms. And I also needed to mention that there are some who will not know. Probably just from the age, they'll be able to tell that, okay, by 51 or by this time, I should not be having my periods. If you don't have any symptoms, then it's fine. But most of them will have symptoms. There's some tests we can be able to do to say that, okay, this patient is also in menopause. Like I mentioned the hormones that we check, although they're not always used because they're not exactly accurate, except in those ones who get at very early menopause. So we look at the level of that hormone called FSH. So if the FSH is elevated, then we say if it's elevated, it means that it's not being taken up in the ovaries. So that's the simplest way I can put it for you. So it tells us that, okay, then this ovary is not responding as it should. So I hope that answers for those ones who don't have a uterus, which, I mean, if it was removed earlier than their menopause. But most of the time, the symptoms of menopause, as I said, they'll be mild to moderate. Most women will experience the hot flashes. That's the vessel, like the blood vessels, we call it vasodilation. You feel it. And that hot flash is very characteristic. It's around the neck and the chest. I'm trying to make it very visual for you. And you feel it moving, like you feel hot, you know? And it comes and it lasts for a certain number of minutes. Most people will experience it for around 4 minutes. And it's very irritating, very hot, like you feel like you need to enter the fridge. That's the best I can explain. And then there are different parts of the body that are affected if your estrogen level has gone down. So let's go to the head. You'll find that all these things happening to you at this time, it's right when maybe you're experiencing some difficulty, maybe with your husband, or you have children around you that are still living with you, and you have a lot of things going on. And then now you have these hot flashes and other symptoms. So you tend to have changes in mood. Your mood changes a lot. So they are very labile. You can go from high to low. You have times you feel like you're getting depressed. Sometimes you feel you're getting anxious. For some people, they get these sleep disturbances. Like your sleep just completely goes away. And you remember this time, it's not the only symptom you're experiencing. You're also experiencing the hot flash together with all this. So at night, you're having night sweats. And the night sweats can be so bad that you're literally drenching your sheets. It's a very, very uncomfortable situation because, again, if you have a partner at this point, they're also getting maybe uncomfortable, you're uncomfortable, and all this is together, you're now feeling very bad and your mood gets low. And this will affect how you relate with your partner at this point. So I said for some of the patients, you'll experience low sexual drive. Again, you remember it's all combined together. You have the feelings of changes in mood, so your sexual drive is not as it was before. There'll be those ones now that completely, you cannot be able to achieve an orgasm as you used to do before, or maybe it takes a bit longer. So you see, all this is all together. Then again, you also experience it. We said sometimes you can get these changes in body structure just because you have low estrogen levels. your bones are a bit weaker, so you can easily get a fracture. Because estrogen is very protective. It helps your bone density to be good and strong. But at this point, your bone density has reduced. You can easily get a fracture. You also have these changes in your cardiovascular, that's the heart and the blood vessels. You start getting maybe these other related diseases like hypertension and heart disease. Yeah, so if I go down to your stomach, you'll experience bloating, because all these hormones work all over your body. So you're going to experience all that. Again, your periods will completely go away, but at the beginning, they start changing. You start having either prolonged, they don't come after a long time, so they increase in terms of the cycle, in terms of the number of days between cycles, and then they disappear completely. So your period just goes away. And then because of this low estrogen, you also have vaginal dryness. In your reproductive years, your vagina would be, because I know we have all kinds of people here, and I know we are at all different levels. Some we are at reproductive age group, you're having these normal secretions every time. But now as you go into menopause, because of low estrogen, you have low secretions and you're going to experience vaginal dryness. You're going to experience, because of that dryness, sometimes there's irritation. You might feel itchy. Actually, the itch can be really, really bad, in a way that you might need some help in terms of reducing that feeling of itchiness. And then, of course, because you cannot have normal, you don't have enough secretions, then it's difficult to have intercourse. You feel pain while having intercourse because of that dryness, and then of course they can easily cause injuries along the vaginal tract. Then again, because of that area, there's also this area called the genitourinary tract, the part where you pee, where you get UTIs. So most women will be diagnosed with UTIs at this point, but it's important to note that this part, the urinary tract and the genital part, when you are being made in the womb, in your mother's womb, they had a similar origin. So it means when the estrogen goes down, it means even your urinary tract area is also affected. And that's why you get pain while passing urine. You pass urine many times, and then it looks like a urinary tract infection. So you're treated for a urinary tract infection. It would be good to at least get tested for a UTI before you're given any medication for that. So yes, all this, even the skin. Remember, the skin is also an organ. You experience what feels like things and then like things walking, it's because of those changes. So you kind of feel like scratching yourself. So all these are expected changes in menopause. It's not anything to be alarmed about unless they are very, very severe. Yeah. Thank you, Posa.
Okay. Wow. Yeah, at least it's really a head to toe problem. And we can answer one of the questions over there. So is there a stop to menopause? Like, when do we say it's gone and done? Like menopause, Elisha?
That's a very good question, because everybody is different. Menopause is basically anything after the 12 months of your last period. So after the last period now, and then it's 12 months later, you're in menopause. So how long do the symptoms take? I think that is the main question. It depends on the person. Most times it'll take up to 4 years. I know that's a long time, but they decrease in terms of the intensity of those features. So it's a period of time around 4 years. Some people take 5, some people 6. And it's unfortunate that some might even have them as long as until their life, some of those symptoms. So yes, we have seen some people going on with that period, but most of the people will experience it only around 4 years. And then after that, it goes away. Now you're in complete postmenopause. There's no symptoms. It goes away completely.
Okay. We can also answer Anna's question. When you have your ovaries removed due to illness, Anna, you get premature menopause, as in it comes early. And so most gynecologists, most doctors will avoid removing your ovaries unless otherwise indicated. Let's,
Yes.
yeah. Oh,
Maybe probably I could add something as far as I think Dr. Karen has done a great job with summarizing and explaining all about menopause. But just to understand that natural menopause is defined when it comes above the age of 45. Usually the average age, like we said, is 51. So above the age of 45 is your natural menopause. If it's coming between 40 to 45, we call it early menopause. If it's coming before the age of 40, that's premature menopause. And there could be many causes. And when it's coming early menopause or premature menopause, then we have to think of secondary causes, like other causes that could be related. And that's where sometimes we also come in. For example, females like at the ages of 30, 35 can have something known as autoimmunity, which is your body's own immune system reacting against parts of your own body. So that's autoimmunity. And autoimmunity especially can, when it affects multiple organs, like what we call as polyglandular syndromes, can also affect the ovaries. So if you get early menopause, it's not only usually due, like premature menopause is not only due to removal of the ovaries, but can also come due to diseases affecting the ovaries primarily. Sometimes it can just be a genetic issue related to early or premature menopause coming in. At times it could be related to some procedures, for example, chemotherapy. Some patients who have cancer and there's like, like Posa said, you have to always weigh the risk versus the benefit. And it's the last resort is when you would get chemotherapy, which could affect your ovaries. But even in that cases, sometimes there's systems or mechanisms in which you can retrieve your, the eggs to preserve for later conception if desired. Because at that age, the biggest worry is conception, because you become infertile at such a young age if you are going through these kind of procedures. So some of these things are preventable and treatable. Some of these you cannot treat. Like if it's a genetic component or, or autoimmunity, sometimes some autoimmune conditions, if you treat them, then you can reduce the risk or attempt to prolong. But most of these conditions, then they come in and they destroy the ovaries without your knowledge, and you realize at an early age that you've got menopause, and that's now known as premature menopause or primary ovarian failure. So that's something that we need to keep in mind as well.
Okay, I know the questions on the chat are about treatment. We'll take some time to manage menopause. I just want us to understand the symptoms and why we get this before we actually treat it. We are putting our medical textbooks and our gynecology and endocrinology textbooks in our head as we go through this. So Dr. Sokwala, how do you differentiate just menopause from normal aging and disease and from diseases that are caused by our lifestyle? Let me give you an example. How do you differentiate the risk for fractures due to menopause from risk of fractures from actually not exercising and not taking your calcium well? How do you differentiate the two? When is it aging? When is it menopause?
So, Posa, that's an excellent question. But one thing I want to bring out to the audience is that menopause is not a disease. It's not abnormal. It is a normal process in a woman's life. So it is something we all anticipate. It is something we all look, hopefully if we age to that age and we reach to those levels, then we do expect to get those features. So it's something as like a part of your aging process. So it is still aging. It's still part of aging. And many of these risks of cardiovascular disease and of fractures is still part of aging. So I wouldn't want to differentiate. I'd like to combine them and do your risk assessment as such. So what we say is this, right? Any female below the age of, above the age of 60, anyways at an increased risk of fractures, especially over the age of 65, regardless of menopause or no menopause. Obviously, most women by that age are into menopause. So above the age of 65, the risk, for example, of fracture, regardless of doing a fracture risk assessment, you need to assess them for osteoporosis anyway. So that is like an age that we don't even, it's not, we don't even argue about it. Anyone above the age of 65, you need to get a fracture risk assessment done, and preferably a bone mineral density done using what we call as a DEXA scan. And now that is widely available in many centers in Nairobi. I don't know how, I mean, of course, in the US, it's available. And I'm sure it's your routine screening that you would get a DEXA scan done after the age of 65. How about under the age of 60? So if women get menopause under the age of 60, for example, like we said, those who get natural menopause or early menopause, or especially premature menopause, at that stage, you have to do a fracture risk assessment for these women using a score. There's a score known as a FREX score. You can easily find it online. It puts a lot of risk factors. So the truth is that fracture risk is associated not only because of low estrogen, there are a lot of other factors, and I'm so glad that you brought it up. For example, just patients having high thyroid levels, like hyperthyroidism, have a higher risk of fractures. Patients using thyroxine, those who have low thyroid and they are on thyroxine, have an increased risk of fractures. Patients who have a family history of osteoporosis have an increased risk. Same thing with dietary components. Those who are having low dietary components with calcium and low levels of calcium, low vitamin D in sun unexposed areas have a higher risk of fractures. Patients with rheumatoid arthritis have a higher risk. So there are a huge category of patients who have a high risk of fractures beyond just low estrogen levels or menopause related risk. So that's a whole score that gives you, and it's actually, the score is per region. There's an African FREX score. There's, a Caucasian FREX score. So there is a FREX scoring per region. There's an Asian FREX score. So I'd advise everybody, if you are in that menopausal age, perimenopausal or menopause, do your FREX scoring. If you score high, that's below the age of 60, and you've scored high on that FREX score, then you need to get a bone mineral density assessed using the DEXA scan, which is the gold standard to assess for bone mineral density. So that is as far as osteoporosis is concerned. As far as cardiovascular risk, which is another question you asked. So generally, again, when a patient comes to you and they have like a female comes to you and they have, high cardiovascular risk factors, for example, like anybody who comes in their menopause, you have to do their cardiovascular risk assessment. So that includes, it's again another very easy calculator to use to check your 10-year risk of heart attacks and strokes. And that's available by the American College of Cardiology and the American Heart Association. And it's known as the atherosclerotic cardiovascular disease risk calculator. So if you just do SCVD risk calculator, it gives you your risk of heart attacks and strokes, okay? And that risk is supposed to be done for every female who comes in with a menopause, with features of menopause or low estrogen levels. So with that, now you determine your risk of developing, whether you have got menopause or not, you can use that calculator. And especially when you have menopause, then, you need to treat it accordingly, because the problem, like Dr. Karen said, is when you have low estrogen, that is it like actually increases your risk of heart attacks and strokes a multiple fold compared to if your estrogen levels are normal. So that risk assessment has to start being done early in females, especially younger females who go into menopause early, and in also those who do have menopause at the natural age. So yeah, I hope I've answered your question, Posa.
Yes, you have. Thank you. Thank you. That was well answered. My other question is, because I have to think of my people in Luanda Dudi, the ones who don't see a gynecologist, will never see a gynecologist. Can we discuss there's something called the climacteric questionnaire. I don't know if it's used in Kenya. I can share it. Let me share it on my let me just share it, then we can discuss it. Like, how do you help patients who can't see a gynecologist or any other medical provider to assess themselves, like tell people that they have Okay, I can't find it. There's something called a climacteric questionnaire. It's a bunch of questions that you ask and tick and just know you have menopause. Is that something we need to use? Are we using it in Kenya or not?
Personally, from my experience, I don't think we are using it. You know, like the knowledge of menopause and the associated, symptoms and complications is quite lacking in this part of the world. Yeah, just like you said, and it's not such a common thing that is used unless patients present themselves to the healthcare providers for any reason. It's sometimes very difficult to know like what they're going through, and there's hardly this culture of self assessment or self-evaluation, or going online and filling in these questionnaires and trying to know what is going on. Many of our women are usually used to doing home remedies for this, unless the symptoms are so severe, or unless they've come to us for another reason, and by any chance that we end up doing, we screen and we ask them about these specific symptoms related to menopause and the risks associated with loss of bone density, cardiovascular risk, increased psychological issues, sleep problems, mood issues. Unless we actively ask, people don't come out. And the health seeking behavior in this part of the world definitely is very different from what you are facing in the US, for example. So that's a challenge, and I think this the questionnaire would be useful. I'd let also Dr. Karen discuss. But before we go to that, another thing that I'd like to tell you is these vasomotor symptoms that we talk about, the hot flashes and the classic symptoms that we attribute to menopause, sometimes can mimic menopause, but could be due to other underlying problems. So that is something that we have to keep heavily at the back of our minds when we are discussing these things. For example, there are patients who we have discovered that they have these typical symptoms of menopause, and when you do their thyroid levels, it is over the roof. Like they have hyperthyroidism, high thyroid levels, or they end up having a tumor in the adrenal glands in one of there's a gland above the kidney which is known as the adrenal gland. So this condition known as pheochromocytoma, or other conditions related to hormonal overproduction. So those things have to be ruled out before we for sure label it as menopause in all women, especially when the symptoms are not that classical as far as the other associated symptoms are concerned. Yeah, I think Dr. Karen can comment on this question. Yeah.
Yes, thank you, Dr. Sokwala. This questionnaire, for those ones who might not know about it, it's a questionnaire that helps you grade your symptomatology. So what happens in Africa, most women, and as I said, almost 60% of most of us will have mild to moderate symptoms. So rarely do they even tend to go to the hospital to present with these kind of symptoms. But for those ones who probably have gone into severe symptomatology, when they show up, sometimes this questionnaire would be important for follow-up in terms of how the medication is working, whether it has improved. So you can be able to tell at the beginning how the symptoms were and then how they are after some time. But unfortunately, because not very many women tend to have you seek for help at this point, most of the ladies will go and talk to their fellow ladies and say, I think I'm going to menopause, I'm feeling the hot flashes, but you endure the pain. So we rarely use it as much, but it would be an important questionnaire to put it out there so that they can be able to tell whether this is something that needs to medical attention, and whether this is something I can just relax and hope that it goes away, because it really does. And again, we said menopause is not a disease, it's just a period of time that passes. After that, you're okay. Yeah.
Okay, now we need to invite the psychiatrist to talk to us about matters of the mind. Kingi, welcome. Let me share your presentation. Okay, let me look for it. But you can give a small introduction as I look for your presentation. And if you're
Hi,
speaking,
everyone.
okay.
Hi.
Are you able to hear me?
Yes, we can hear you.
Okay. My name is Dr. Kingi Mochache, and I'm a psychiatrist. And I've enjoyed the session. It's helped me remember obs-gyn and endocrinology and all that. But I'll be quite summarized. I'll present about the mental health aspects of menopause in a very basic way. I will not be talking about FSH, estrogen, LH, all those things that the endocrinologist was talking about. I was informed that the audience is mainly lay people, not medics. So we'll start my slide.
Are you able, okay, when you share slides, it's usually weird. Are you able to see them?
Yes, but I can see the whole page. Let me try.
Are you able to
Presenter view,
move them
maybe
from your
you could
side?
go to presenter.
Let me try.
Do I stop sharing?
Yes, stop.
Okay, just try on your end. If you're using your phone, it's a Zoom thing.
Are you able to see anything?
We're just seeing you.
You're seeing me?
As in, okay, maybe it's because you see, I have the presenter's view, so I'm just seeing you. We can't see. Are you using your phone?
Yes, I am.
Okay, the phone is usually like virtually impossible. Okay, no, let me try and share. I will try and put it into presentation.
You still can't see?
No.
Okay. No,
okay,
I don't even know how to. Yeah.
Let me share it. I will try and find God. Okay. Where is that thing? You know what? Let's just use it the way it is.
I think it's
Also,
right.
I think down there
below.
you can go to
You can
presenter
see it.
view,
Okay.
slideshow.
There, right?
Yeah.
Yes.
Yes.
Thank you. I wasn't seeing it.
Okay. Okay, now we can go to the next one. So by the way, the thing I wanted to just make sure for people who are not medics, I know for us as doctors, there's something we might take for granted that people understand, but they don't. But I've seen that a lot, especially here in Kenya. Remember, a hysterectomy is very different from removal of ovaries. So it's not what causes some kind of menopause. A lot of ladies just confuse not having a uterus and not having ovaries. So someone who, what the obs-gyn, I think, should just elaborate that in a very basic way so that people know where the hormones come from is different from where the baby is housed or where periods come from. Now, in matters of mental health, I know people say during menopause, it's like going through adolescence. Actually, what we talk about as the difficult period is the menopausal, perimenopausal period, or the transition from being reproductive in your reproductive years to non-reproductive years. So it's that transition. It could take 2 years, it could take, I don't know how many years. So it's different for everyone. And that's where the symptoms that were being described come in. So as in matters of mental health, there's an increased incidence of anxiety and depression among women undergoing during the perimenopausal and postmenopausal period. It's not always related to hormonal changes, but the hormonal changes may exacerbate things. Most of the time in psychiatry, in fact, this menopause is a very short topic in psychiatry. There is surprise. And the reason is most of the time, it's not exactly the menopause that's causing all the symptoms. It's usually a lot of psychosocial stressors that go on for different women during that period. These are like commonly during the menopausal, perimenopausal transition time is when your children are also adolescents. So there's a lot of difficulties in the house. It's also the time when maybe financial stressors start peaking. It's also the time when you're trying to understand what with my career. It's also the time when maybe your hubby might start, it's called midlife crisis. It's also the time, so there's a lot of psychosocial stressors, and actually the biggest ones are related to your home and things happening in your house or where you stay. And women mostly care about their children and their spouses, family, unlike men who more commonly will be more stressed about like financial or work matters. Now, another reason why this depression or anxiety, mental health disorders may spike during the perimenopausal period is usually a pre-existing mood disorder comes up. So already one had been treated for some few diseases that I'll talk about here. And because of the hormonal changes, just in the same way that the first depressive episode or the first bipolar episode usually is in adolescence, it is also exacerbated by now those same hormones disappearing. Let me put it that way, instead of using all the different jargon. Posa next.
Gosh. Okay, yeah.
So for depression, 20% of women experiencing the transition of menopause will suffer a bout of depression. And sometimes it's because of an increase in some testosterone in the mix of all those estrogen going down and everything. The endocrinologist will comment. But remember what I said, it's mostly because of the psychosocial stressors or a pre-existing depression that you were treated for earlier. Next. The symptoms of depression are just standard. There's no difference in depression in a perimenopausal person or another one. It's usually these 9 cardinal symptoms according to DSM-5, which include low mood, loss of interest in things that you previously enjoyed, increased sleep or reduced sleep, increased appetite or reduced appetite, so it changes also your weight, homicidal or suicidal thoughts. These are not as direct. I know people shy when they hear of this, but sometimes it starts with things like feeling worthless, hopeless, there's no way out, and it ends up to I'd be better off not alive, I'd better join, I don't know, someone who, a loved one who passed away, and that's how it ends up in suicidal thoughts. It's not as far as people think. Then you may have slowed or hurried thinking and movement. This is typical, and it overlaps. The next slide is about overlapping symptoms of just menopause and depression. Indecisiveness and reduced concentration. Next. Now, these overlapping symptoms would be there whether it's depression or not, and they've been talked about a lot. And these include reduced energy. So one of the symptoms of depression is when you lack interest in anything, you don't feel like getting out of bed, you don't feel like going to work, you don't feel like cleaning your house, cooking that new recipe. Suddenly, there is no energy to do anything. Impaired concentration, sleep disturbances, sleep is a big deal. Weight changes, so you know there's this big thing people say that once you add weight after a certain point, it's so much harder to lose it. And libido changes, which have been talked about here a lot. Next. Now, sleep difficulty. This 40 to 50% of perimenopausal women will experience this. And this is the point where I'll mention a few hormones, and the endocrinologist will help me. I will not give all the details, but there's something called luteinizing hormone, LH, which may increase during that perimenopausal period, and it usually affects the quality of sleep. So there's the duration of sleep and there's the quality of sleep. Sleep difficulties are not just about I did not sleep. Sometimes you sleep but you don't feel rested. That might be affected during the perimenopausal period. Then estrogen deficiency. Now, There's this common, like, I don't want to say it's a joke, but in mental health, we usually say that estrogen is protective. You'll realize that during the time when you have estrogen in your body, you may have mood swings, you may have all that, but there are a lot of psychotic illnesses that are shielded. And once you pass through menopause, sometimes now you don't have as much estrogen as before. That might cause a problem in terms of certain mental disorders. Then there's sleep apnea, which is related to other hormones. And then anxiety, tension, and depressive symptoms will increase if you don't sleep properly. In fact, my last slide is about management of depression. One of the most important things is to try and fix sleep. If you just fix sleep, sometimes you don't even need to do the psychotherapy and the and the medication and everything else. Next slide. Schizophrenia is a psychotic illness, and the second peak for women is between 45 to 50 years. So this is the thing, the illness which you'll find women in their reproductive age somehow rarely get. I don't want to put it like rarely get, but it's protective of that age. In fact, majority of the young people, so people below 45 who suffer schizophrenia, a large number, not all, are usually men. Schizophrenia may start during adolescence, but usually they say before 25. Now, the second peak for women is usually between 45 and 50 as estrogen is declining. Next. Panic disorder. Now, this is the most common one, and it's more, everything about panic borders a lot with endocrinology and cardiology. The reason is a lot of the symptoms are similar. So you see, when you look at the list that Dr. Karen had presented about menopause, you'll find that a lot of those symptoms are actually like uncomfortable and scary. You know, things like sweating, you might have palpitations, and panic disorder, if you had it before or if it is coming up now, it's worsened during this menopausal period. It's also worsened by negative life events. So whenever there's maybe a divorce, a job loss, a child who's unwell, a child who is stressing you, adolescent, teenagers, all that just worsens a perimenopausal woman going through menopause. Then there's functional impairment. You see, if you're having such severe night sweats, sometimes menopause symptoms can be so bad that you're not functioning the way you used to or you want to, whether it's in your house, whether it's with your own staff, or whether it's with your job. That might worsen the panic. Then medical comorbidities, which have been talked about here. So things like diabetes, hypertension, around this age is when you start getting all those diagnoses. Sometimes cancers, different kind of illnesses are discovered, and they just worsen the panic disorder. Next. Next slide, Posa. So the management, this is actually my second last slide. So for those who are asleep, management of mental disorders, as you've seen, I've listed, I've only talked about 4 mainly, but there are so many. And I'll talk about depression mainly. Now, there's this thing called hormone replacement therapy, which the endocrinologist and the gynecologist will talk about. My message is this. First of all, in mental health, we will rarely start this or recommend this. We will send you to the endocrinologist to do it. Remember, anytime you're tempted to do this over-the-counter stuff and go, I don't know, you know, the way women, we get together in Chama and I don't know what, and advise each other. Be careful with these things because they have their own risks. When it comes to mental health issues, the only evidence of using hormone replacement therapy is when the depressive symptoms or the panic disorder symptoms are being caused by the physical symptoms of depression. Hormonal treatment may also augment, help the effect of the antidepressant medication that you may have been put on. But standard treatment methods for depression and anxiety are used. So instead of trying to stop, replace that estrogen that you don't want to go, it's, I think, some kind of grief and loss. You're better off embracing it as not a disease, something to reverse, but instead go and get proper advice from an endocrinologist or an obstetrician on how to manage symptom by symptom. Next. So this is my last slide. Depression is managed in the following ways. The first one is environmental adjustment. So if you're depressed because maybe you're working in an environment where your boss is always on your neck, or you're depressed because you're in a relationship that's very, very difficult, manage that first. Don't try to stay in a, okay, I know there's a lot of balancing to do. It's not as easy as black and white, but I keep telling my patients, it doesn't make sense to be taking antidepressants over and over and you're in the same difficult environment. Number two, regular self-care. So as I mentioned, sleep hygiene. Sometimes when you just sleep, all these depressive symptoms disappear. And I'm not saying we should take over-the-counter sleeping pills. Balanced meal, the same old things people talk about. Just make sure you've eaten healthy, get into the habit of whether it's 3 meals, whatever diet plan you use, let it be nutritionally balanced. Then physical activity, exercise. This completely, research shows that aerobic activity, 30 minutes of aerobic activity daily will actually reduce symptoms of depression and anxiety and improve your concentration and attention. Finally, address medical illnesses. Just because you went somewhere and got maybe a pap smear that was not very nice, sometimes people just shy off and ignore it. It doesn't help because in your subconscious, you're still worried chronically. Address every medical condition you can to the best of your ability. Follow your clinics. If you have hypertension, if there's something being discovered, just gather energy. Come see a psychiatrist or someone to kind of give you some psychological support, but address any medical illness you may have. I know Kenyan, I don't know whether it's our people, maybe I'm also in that category, but we have a habit of really ignoring illnesses. Like when you find out something, you decide, okay, I'm not hypertensive, that was a mistake, and I'm going to do I don't know what, and all that. Then where we come in is talk therapy, psychotherapy. It's not, there are different types of therapy. And especially for us, like psychiatrists, we rarely do just that general counseling. It's very structured psychotherapy. So like CBT has a whole module. When you come in, there's an assessment. There's a way you look at different problems, how to handle each. It's very, it's based on a precept in summary that says that your thoughts determine your mood, which determines your behavior. So sometimes you don't treat the behavior. You start from, it's a loop. What thought made my mood go down and then made me react in this way? So it's a very structured kind of therapy, and it's actually prescribed in, yeah. Finally, there's medication. Do not shy away or fear antidepressants, but also do not take them over the counter. There are different antidepressants. Not all psychiatrists will always rush to medicate. They have their role. There's a proper way that assessments are done, and sometimes you just really need to take them, and they need to be monitored, and not all antidepressants are the same. Someone may have a heart problem, so the kind of antidepressant they take is different from someone who is 17 years old, or someone may have a sleep issue. Someone else might have too much sleep. Their antidepressants will be different. So just get a psychiatrist to assess, or even a GP. And my last message is, please let's not take over-the-counter sleeping pills, no matter what. I know melatonin is natural, herbal, but in terms of things like benzodiazepines, addictive sleeping pills, please, let's not take them. I know Kenyan women of this age group between above 45 generally have a habit of over-the-counter sleeping pills secretly, especially the ones who are medics, and also another habit of painkillers like Betapin. Thank God it was made illegal. Those things have addictive substances like codeine. It gets you into another hole, which is a whole different mess. Having said that, you can seek help anywhere. There are private hospitals. Mental health is not always expensive. It's like, I'm in Nairobi. In Nairobi County, we actually have mental health services in almost all the health centers, in Bagati, in Mama Lucy, in Kenyatta. So if finances should not be your hindrance to getting help, that's all. I'll take any questions.
Yeah, if you have questions for Kingi, because she has something to attend to, please put them in the chat, or just put them in the chat. And that was very super comprehensive. Oh my gosh, yeah, it was very, very, from a psychiatrist's point of view, it was very well done. And I think one day we will tackle the sharing of medication by, I think it's a Kenyan thing. I don't know if other people do that, but we need to it's a whole topic. But let's go back to Karen, unless people have questions for Kingi, because she has to step out in the next, Kingi, 8 minutes. Yeah, in the next 8 minutes, Kingi has to leave us. But let's go back to Karen. And if you have a uterus picture, just put it up. Do you have one? Or I can hunt it from the internet. So that, because we need to explain to people the different parts, because it will help with the sex questions, it will help with the salpingo-oophorectomy. You know what we are talking about. Yeah. Yes. Do you have one, or should I put a tiny one?
If you're able to put one, it would be nice. So yes, there was that need to elaborate what it really means to
is that a good size?
Yes, that's fine. That's fine. Let me move my, okay, now I can be able to see it very well. So I hope all of you can be able to see that. So this is just a simple picture of what the uterus is. And I'll give it as simple as possible. I won't go into all the details, but imagine if you can see me on my photo, if you're able to imagine if something was cut this way, okay, this way, in a way that halfway, in a way that you can be able to see the uterus. This is the visual you're going to be able to get. So what you can see there is basically the uterus, that thing that looks like it has hands, long hands that go and hold on to that thing, the brown thing called the ovary. So the big part is called the uterus itself with the fundus. And then those are the tubes that look like the hands. And then the hands go and they touch onto the ovary. So when we go in and have a hysterectomy, that is now removal of the uterus, we are only removing that part I've said is the body of the uterus. I hope it's easy, because I don't have a pointer here. Posa, are you able to point on the screen? Point onto the uterus. You can circle it. Oh, it's not coming. But anyway, yes, there are different types of hysterectomies, that's removal of uterus. Most of the time we remove just the uterus, and then we leave those ovaries, the brown things you see there. And depending on what condition you have, and most of them, let's say you have fibroids or whatever it is, we remove just that uterus, and then we remove it together with that cervix. The cervix is down there, and then we leave the vagina intact. But if someone has a problem with the ovaries, maybe it's a cyst, what we suspect could be cancer, or there's a problem with the ovary, maybe it twisted and then it died. Most of the time we remove either one ovary, depending on the condition. If it's just affecting that ovary, that means the other ovary on the other side will still work as well, so you don't go into menopause. But if you have a problem with both ovaries, sometimes depending on the condition that we are dealing with, for example, if it's let's say a 19-year-old, because we also have 19-year-olds with ovarian cancers, and you can see that that cancer has affected only one ovary, and the other one, when you examine in theater, it looks normal. We just remove one and then we leave the other one. But if both of them look abnormal, sometimes, or if they've confirmed that it's cancer, sometimes you remove both ovaries. And in this case, you'll find now, because without the ovaries, you don't have the hormones that give you your period, and therefore you don't have those hormones that prevent you from going into menopause. So this is when you get now those patients who actually go into premature menopause. I hope that is clear. So yes, when we say we're removing just part of the uterus, as you can see in that photo, there's usually the subtotal, although these days we do most of the time the total hysterectomy, where we remove only that part of the uterus and leave the ovaries. But if it is a patient who has cancer, we've seen that the ovaries are affected, we do this radical hysterectomy, the one on the right. I hope that is clear. Okay, so I think I mentioned some things about treatment in terms of menopause. Menopause is not a disease, it's a natural period of time, just the way you go into into puberty. So it's expected not to give you severe symptoms. But in case that you have severe symptoms, this is where we encourage you as ladies, if you feel that this is too much, I cannot handle this alone, you need to talk to somebody. This is a multidisciplinary approach situation, where now, of course, you can see we have the psychiatrist, the gynecology, the endocrinologist around, or if there's other issues in terms of, let's say now you're having other issues like cancer or blood pressure or diabetes, we also involve other doctors. So don't suffer alone. That's the message. If you feel like it is on the survey, and I think we'll be able to post that questionnaire where if you're experiencing any symptoms, you can be able to tell whether yours is the severe form. So if you're experiencing moderate to severe that you cannot handle alone, make sure to reach out to any one of us. So if, like now in this case, when it comes to our gynecology, we look at your symptoms, we see what we understand, we listen to you, you tell us what the problem is. So it could be any of those symptoms that give you the worst experience. Maybe it's vaginal itching, because again, we say that vaginal itching can just be because of menopause. Then there's some things we can be able to do about that. So assuming, so I'll talk about a few things that we'll handle, and then the ones for the hormone therapy, Dr. Sopala will be able to give us some information about that. But those symptoms like the mental changes and all that, we usually send it to the psychiatrist and we discussed it comprehensively. But things like vaginal dryness, because that's what most women will come with, vaginal dryness, and of course associated with itching, and then you have now difficulties in having your normal intercourse. I think I've seen a question there about having intercourse, whether when you go into menopause, you stop having intercourse. You don't need to stop having intercourse. You still can be able to continue with your life as usual. But now if you have any severe symptoms, that's when you can come to us. If it's about the dryness, we usually use vaginal creams. And I think we mentioned some of the natural therapies that you can use and bioidenticals. So what bioidenticals means is, instead of having, because you can't get estrogen from a human being, we make them like in terms of synthetic version. So we can use those synthetic estrogens, especially we can use it as a cream to help you reproduce your secretions as usual. But it's very important to know that you don't prescribe this to yourself. This is a very important hormone that needs to be monitored. There's some effects that you can get with estrogen, just estrogen alone, that all of you need to be aware about. So don't treat yourself. Don't go and get a vaginal cream that has estrogen. Let us be able to help you through that. And I'm sure Dr. Sokwala will talk about the effects of estrogen on its own to you as a woman. There are people we may not be able to give them estrogen as hormone replacement therapy. For the itching, there's some things that you can be able to do. If we give you creams, the itch might reduce. Then you should be able to have intercourse normally. But if the itching is there, sometimes we're able to give you natural ways to reduce that itch. For example, I'll use an example. If it's not about the dryness, but you're very itchy, we of course check whether you have an infection first before we tell you what to do. So if you have no infection, then you can even use things like very cold compresses on those areas where you're feeling the itch, because when you do that, like you can use maybe a piece of soft paper in your house with ice and then attach it to that place where you're feeling itch. It's a very temporary thing, but it gives you time at least so that you can heal when you're on your medication. So for intercourse and your drive, all that, as I said, everything is together. It could start also from the fact that you're stressed out. There are many things happening. Your partner might not be understanding you the right way. So you have this, you're not able to enjoy sex as you used to. But as I said, there are people who actually at this point, instead of having a low libido, there's some. So it's not, don't be worried if you have a higher libido at this point, because again, you say that the people who are even changing partners at this point, and you know, this can change in terms of the stress level. So you're not stressed, so you're not having difficulty in having any sexual problems. So that's what I would say about sex. But again, if you still have those problems, you can still have someone to help you through it, talk about it, use lubricants. By the way, just be free to use the water-based lubricants. They should be okay with you if you feel like it's about the dryness. But in terms of getting to a climax, sometimes it starts from the thoughts. As we said, the thoughts control your behavior, eventually. About the periods, I think there's someone who was asking whether we can return you back so that you can be able to get pregnant. So menopause is, as you said, is a normal occurrence. And why you're going to menopause is because your egg reserve has gone down. It has gone down. So we might not be able to tell you now, we'll give you, because yes, we can give you medication, but that medication will not bring back an egg to be produced. And even if one is produced, it will not be as healthy as it should be. So you have to remember, when you're going into menopause, if egg reserve is low, then you will not be able to conceive as usual. Yes, there are people who have conceived only during the perimenopausal time. And there'll be these ladies who had a menopausal baby. So it would be important for you to know that using the usual contraceptives should still be used even up to a certain time during your menopause. For sure, there are people during perimenopausal state, because I said estrogen just goes up, it goes down, it goes up. At this point, it's not sure at what point. So you're also producing an egg, and sometimes you can even ovulate twice in a month. So during this time, when you're starting to feel the hot flashes and you're still having a period, you can easily get pregnant. So don't forget to still continue using your usual contraceptives, or be careful during intercourse, because you can still get a menopausal baby. Not a baby who's menopausal, but during menopause. Yes. I think for natural remedies, I saw a question on phytoestrogens. These are found in food like soybeans, the ones that have estrogen. They cause you to have an increase in estrogen level, like alfalfa. We have some legumes also that can increase your estrogen level. They are good to use, but again, you'll need to then have a lot of them, ingest a lot of them to cause a significant change in your symptomatology. So to be important to know, some people can start during their perimenopausal state. When you start realizing that your periods are changing, then it means you're heading towards menopause. You could maybe increase the level of the diet, the phytoestrogens in your diet. Again, everything in moderation. There's also the herbal medicines. It's not our area really of information, because we don't really do herbal, because they're not really regulated according to what we studied in medicine. But again, we do not dispute that there's some herbal things that might help you go through your menopause. But again, remember to always communicate with your doctor or your physician on how you're going on about it. Yoga, I think in terms of mental health, there are people who take up yoga very well. I think it depends on what you want: relaxation, meditation, prayer. It's good to mention that if prayer helps you, then why not, it can help. It's some form of meditation. Acupuncture has also been mentioned before, that some people usually use to reduce some of those symptoms. But if all this is not working, and we've tried even talking to a psychiatrist, then we move up to hormonal replacement therapy. So I think I will forward this to Dr. Sekwala. Maybe you can give us some insights on this.
Thank you so much, Karen and Dr. Kingi. This, I think you've summarized, and you've actually I shouldn't say summarized, you've detailed menopause and simplified it in such a beautiful way that I think our attendees have really learned a lot from whatever you have said. And most of it, as we have seen, is a lot of the issues that augment or increase symptoms of menopause, which coincidentally occur at around the same time as menopause occurs, which is in your late 50s, 60s, that age category, where also your other risk factors, as we mentioned, also are setting in. So clearly it's quite an interesting but yet very challenging space for a female, and you need support. So don't be alone in it. You need to seek help, especially if your symptoms are not being handled with the non-pharmacologic or the non-medical treatment related options. Then you need to come out. For example, if you have got these flushes, hot flushes, and yes, you have confirmed that this is due to menopause, but now you have tried this, all the non-pharmacological, you have tried even like psychotherapy, you have gone through all other forms of non-medication related, yogas and all that, and yet you're not seeing that there's any difference, you're still having issues. You need to reach out to us, because now there is the whole option of giving you hormonal therapy. Remember, that means that your estrogen levels are significantly low to be continuing to cause these symptoms. So then we've got options with hormone therapy, and we've got the tablet forms, we've got the patches. Nowadays, we even have the patches, what we call as the transdermal patches, which are attached to the skin, and you don't have to take it actually as tablets, which have smaller portions of hormones. Now, remember, the hormones that you use for the pill, the normal contraceptive pill, the component of that hormone is the composition or the concentrations are different from the hormone replacement therapy that we want to give you in your menopause. It's known as menopausal hormone replacement therapy. And before you are given those hormones, and I know very many females, especially those who come to my clinic in our part of the world, fear hormonal therapy because they think that it's related to a high risk of breast cancer, it's related to a high risk of weight gain, it's related to a high risk of clotting. And the fears are not completely fake, it's not myths, these are true fears. And so that is why you need to be done a good assessment before you embark on these hormone replacement therapies. So we need to do what we discussed earlier, your risk of heart attacks and stroke. So in patients who have had a heart attack or a stroke, or they've got blockages in their blood flow supplying to the different parts of the body, like to the arms or the legs, then those are people who do not qualify to be given hormone replacement therapy. We'll also ask for a detailed risk of breast cancer. So if you have a high risk, there are questionnaires actually that are filled. Again, we do it in the clinics to assess your risk for breast cancer. If you have a high risk of breast cancer yourself, or if you have had breast cancer, then we usually keep you away from hormone replacement therapy and we go to the non-hormonal options. Then the other question that you will be asked is the risk for clotting. So if you've had a blood clot, let's say in your legs, the deep venous thrombosis, or in your lungs, some people could have, or in the brain blood vessels, then we do not give you hormonal therapy because that is definitely a very high risk. Hormonal therapy carries a high risk for worsening or developing of clots in those patients who are at high risk. If you have a family history of blood clotting problems, then again, hormonal therapy is not for you. Again, we do your assessment of the sexual history. We take your, a full history related to mood issues, to psychiatric issues. And that all has been discussed in detail. I'm not going into the depth of that. Now, when we look at non-hormonal therapy as well in the same regard with pharmacotherapy, then you've got options like, for example, for the hot flashes, there are some antidepressants, like drugs that we otherwise would use for depression, which could carry a double role now. When you're giving them which will also help relieve these depressive symptoms or psychiatric symptoms, and at the same time help with the vasomotor or the flushes and those kind of symptoms. Remember, hormone therapy helps with reducing your symptoms related to the flushes, to the vasomotor symptoms, but also helps with the vaginal symptoms and the genitourinary symptoms, which Dr. Karen discussed in so much detail. There are some studies which show that they could have a positive effect with the psychiatric symptoms as well. And also with, in some cases, like especially when they are given below the age of 60 or earlier on, then also improving your risk of cardiovascular disease. So if you've got a heart attack or a stroke, then we don't give you. But if you're young, your risk was very low, then we do give you, and they do help to reduce your cardiovascular risk to an extent. Again, if you've got diabetes, for example, then you are at a high risk of heart attacks and strokes anyway. So in that category, we do your risk assessment and we decide whether you can get or not get. Again, hormone therapy is of two different types. Okay, so depending on whether you have a uterus or you don't have a uterus. So there's this which only have estrogen, which we talked about. That is given for patients who actually don't have a uterus. But if it's a combination of estrogen and progesterone, then that's what's given if you have a uterus. Again, for the vaginal creams, like Dr. Karen mentioned, that you need to be given the estrogen preparations only in combination or after you've discussed with your doctor, because especially for women who have got a high risk of cancer of the uterus, then these creams are avoided because they increase your risk of developing uterine cancer. So that's why these are drugs that you're not supposed to be given without monitoring. You need close monitoring. Even after you have started the drugs, we do follow-up visits and we ask you questions about your risk and keep assessing your risk at regular intervals. Now, for patients who have got premature ovarian failure, like what we discussed below the age of 40, what we do is we start you early on this hormone therapy. It's best given early on, and it's continued till your usual age of menopause. Okay, and then we do risk assessment and see whether you need or not. For those who are started like at their usual age of menopause, we prefer not to start them over the age of 60 years. And if we do, then we have to be extremely cautious about all these risks, because anyway, the risk of heart attacks, strokes, clots, breast cancer is higher in that age category. And again, the best time to give is if you have got menopause for less than 10 years. So for example, a patient comes and her symptoms of menopause started more than 10 years ago, then that's not a patient I would rush to give hormonal therapy, because now their risks are more than the benefits that they could give. So then I'd go for the non-hormonal therapies. And the non-hormonal I was talking about was the antidepressants and the other forms of therapies that we could give. Again, there's this drug known as Tibolone, which is neither here nor there. It's a steroid preparation, should not be given in patients who have breast cancer, but it is a bridge gap between the exact hormonal therapy and the non-hormonal therapies. And we've seen many patients improve. Now, phytoestrogens, which Ratari again was talking about, is in food, yes, it is there. Like she said, you'd have to eat a large amount to be able to get those benefits, but there are preparations also available. Again, this is not entirely evidence-based, based on large trials, but small studies, and from clinical practice, I'd say from what I've used, they do help, especially in women whose risk of have a high risk of breast cancer, heart attacks, and clots. So those patients who the hormonal are definitely not supposed to be given, then those patients we usually go for the phytoestrogens, and they come in many forms. There are some natural preparations. I wouldn't like to mention specifically which drugs I'm talking about, but there are different preparations that are available. So I think when you do get, like we've discussed, the whole journey of menopause and the whole spectrum of who can be involved to help you. So please seek help, don't suffer in silence. We are all there sitting to be able to assist you through your journey of menopause as smoothly as possible. Thank you so much, Posa.
Okay. Do you guys have any other questions? And we've talked about all the negative things about menopause. So what's menopause good for? Like what gets better because we went through menopause? And that's, yeah, any of you can take that up. Or it's just a done deal. We just have to suffer through all these things.
That's a good question. But all these things that happen to us they're meant to be natural. It's a state of change. Your uterus has been working for a very long time. Every time you have a period, it stops. You have a period, it starts. Our organs have worked and have done a good job. So everything that starts at a certain point should also stop, because you need to rest. We need to stop having children, because again, there's that period that's good for conceiving. Can you imagine if we will be conceiving at 70 years or at 80 years? Our body structures may not be able to hold the physiology of a whole pregnancy. So it's a good time to, it's a difficult transition, but once you're done with it, you have this beautiful time of rest. Your body gets to rest from all this estrogen and all these hormones that are changing your body. Then again, there's also the benefit of the fact that, like things like fibroids, things that are brought about by estrogen levels, at this point, then you're really likely to develop things like fibroids or this reproductive age issues after you're done with this year. So it's really, the transition is not good, but the ending part is just for you to rest and relax as your body should. Yeah.
I think that's so brilliantly answered, Dr. Karen. One thing I know for sure is that you'll not be bleeding every month. So I think that's a plus point. And so you'll save on some of those, pads that you use. But that's on a lighter note. But basically, yeah, I think it's a transition, right? It's a transition phase. Remember, at some point, your body will take up production of estrogen from its fat stores. And that's also some good news, that some estrogen is still going to be produced from our body's fat stores and the adrenal gland. So it's not all lost. That's why you get that shock of the body that when the estrogen goes off. But why do you think the symptoms resolve? It's because your body then picks up its own production of the amount of estrogen you need to suppress those vasomotor symptoms and all. But the good news is this, that, you've been focusing on children, you've been focusing on your husband, you've been focusing on the kitchen. You've just been focusing on everything other than yourself, even the career bit. And you should take this as a time now to focus entirely on yourself. Remember, one of the things that helps with these menopausal symptoms, and which we should be doing even before we reach menopause, way before, on our daily basis, is routine physical activity, good exercise, good diet, keeping healthy. That itself, and keeping your weights in check, that itself has definitely been shown to improve your symptoms of menopause while you have it and also before you get it. So definitely that's something that we can do on a regular basis to help prevent those symptoms. And then remember, if you're focusing on your own health, if you're preventing diseases coming into your health, because good exercise and good diet and all that will also help you to reduce your risk of osteoporosis, will help you to reduce your risk of cardiovascular diseases. So all these associated attached comorbidities, including also psychiatric health, definitely it improves your psychiatric health overall and well-being. So you mitigate or you reduce the risk of getting the symptoms related to menopause and the risks associated with it just by focusing on healthy living. I'm not saying that you should just start focusing on yourself once you are at menopausal age, but from the beginning. But the truth is that what I feel, and I probably when I go there, that's when I'll know what exactly it feels to be there, is that you now start, or rather pay more attention to yourself, put more focus on yourself and give yourself priority instead of focusing on having kids and having to take care of that at that age. So I think there's a positive point to it as well at the end of the day.
Okay, well, self-care it is. We've been at it for 1.5 hours, and we need to wind down because I have to do church also, because yes, God is there for me. But I just want us to have closing remarks. And while you're closing, what tests would you recommend for us to do in this as we transition through wherever we are, pre, peri, or post-menopause, or what tests do you want us to do? And it could be in your field, or it could be in another field. And what's your menopausal dream team? Like if you had Jeff Bezos kind of money, who would you want to be managing your transition through this natural period as we wind down? And Kingi, if you're still there, because I can see you, but I'm not sure if you're still on, you can start as, because I don't know you. Yeah. Kingi, are you still there? Okay, Kingi must have left. Okay. Oh, she's still there. Oh gosh. Okay. You're mute.
Oh, I was just listening. You'd like me to give closing remarks?
Yeah, closing remarks, and which tests would you want us to do during this transition period? And what's your menopausal dream team? Like if you had Jeff Bezos,
okay, so
money, yeah, who would you want to walk with you through this journey?
I didn't understand that.
Like if you had a lot of money and you're going through menopause, what's your dream team? What's your dream medical paramedic dream team?
It's like this one. So I'd see the gynecologist, I'd see the endocrinologist, and then I'd also see a psychiatrist or a psychologist. So those are the people I'd see. But remember, it's only if. It's not about, okay, I know you said if I had all the money. It's also if I felt the symptoms were out of hand. So because I already know it's something everybody has to go through, I think I would just sit it out in the beginning. But if I get overwhelmed, I find that I'm not functioning, I would actually seek that help. In terms of tests, I think the best place to start is actually the OBS-GYN. So the first place I'll go is the OBS-GYN. There are other tiny little factors which maybe we didn't discuss. When menopause comes very early, you know, that's sometimes also an issue with grief, and maybe you wanted children, among many other things, or maybe menopause comes and you still didn't have any kids. All those factors, first go see the OBS-GYN. Let them tell you all the options. Then after that, I'll move to she'll send me to the endocrinologist. And if it's the psychosocial factors that are overwhelming me, the psychiatrist. So there's no test. I don't want to say that there's a particular test I'll tell you to do for mental health. Just check whether you're functioning.
Got it.
Okay. Yeah.
Okay, and you've
thank
done
you
your
for
closing.
this opportunity. And you know, I'm avoiding pronouncing the Dr. So something.
Sokwala. It's phonetic. My gosh, it's Sokwala.
But I've learned so much from you. Like really, it was a good revision class. Thank you. And Dr. Karen too.
I'm chopped liver over here, right? Okay, go. Karen, do you want to go? And yeah, just closing remarks, your dream team, and anything we missed out. Yeah.
Okay, at first I wasn't also sure what would be my dream team, but if I was going through menopause or perimenopausal situation and I'm having mild to moderate symptoms, then my dream team would be, I would first take them all to Maldives and have an AC house with a swimming pool. I can just dip myself and control the temperatures. And of course, have my dream team being the gynecologist, psychiatrist, and of course, gynae, endocrinologist, and psychiatrist all together with me as we enjoy ourselves. So yeah, that's if you have all the money, but we don't have all the money. So but the fridge exists, so we can manage the hot flashes. Yes, but I wouldn't say there's an exact test that we can do to say that I'm in menopause or not. As I said, FSH can be tested, it will be elevated, but it is better to test those ones who are going into premature menopause, because that's the way to confirm that they're in premature menopause. But otherwise, for anyone else who's a certain age from 40 and above, 45 and above, most of the time you already know, it's a self-diagnosis. You don't need any test, but it would be very important to just do your general checkup. As you say, you can have your cardiovascular issues. You still have to do a pap smear. If you've never done one, just at least one before you go into full menopause. It would be important to do your blood works, check whether you're okay, check in with the cardiologist, because you might want to increase your exercise. There'll be, of course, a bit of a stress test they can do. The one you run on a treadmill and they check how your heart can take it. So if they give you a go ahead, go and work out, my friends. You will be fine. Just know and remember that we are here for you. We want to help you through this way. If you're having those severe symptoms, don't suffer alone. You'll be fine.
Okay, Dr. Sokwala, and then I'm not so sure. Someone asked about if there's a blog that someone writes that caters to us, because these blogs are usually from my side of the oceans. Is there someone who's curating a blog that talks about these things and like the stuff we've put out today? Is there someone doing this? Do you know of any?
Currently in the country, I haven't identified one specific person who's doing only menopause, but there are a couple of us who do some work on YouTube. And well, I'm at fault because I've not talked about menopause. I've just talked about the periods, the same usual thing, vaginal discharge. But yes, it's true, we need to concentrate on menopause. But there are some people like myself and a couple others who do YouTube, Instagram information on different women reproductive issues. So yeah, you can follow me. I usually tag them as well sometimes on my Instagram page. So I'm not the only one. So I also post there are other people who've given some content. So you can find me on K Muthembwa at Instagram. And then on YouTube, I do the Gynae Talks. Yeah, I'll write it down.
Okay, yeah, you can put it in the chat. So Kwala, you're winding this up for us. Go ahead.
So Posa, thank you so much for this session. Seriously, thank you for inviting me. I appreciate, I know it was a little tough to squeeze in, but I truly appreciate being part of it. I'd love to do other sessions with you as far as I can impart some knowledge to our people, wherever we are. And at least even if one person gains one thing out of this whole talk, I think it's a successful session. If you ask me about who I would go to if I had all the money in the world, the truth is that I wish I had Dr. Karan and Dr. Kingi at my disposal, and I'd have the whole team ready to be able to go to them. But the truth is, even if I don't have the money, any doctor we can get access to, I think, if as a patient or as an individual, if you are suffering, and whatever access you have, where you have it, go get it. Don't suffer alone. That's all what I would say. You can Even a medical officer at the level of just a qualified medical officer, if you just talk to them, it will help you. At least it will help you to understand better from your perspective. They'll be able to do some tests to know your risk factors, to be able to guide you on how you can take care of some of these things, and to be able to link you to the right people, who can help you even further where they get stuck, whether virtually, whether physically. Yeah. And I think I've posted my contacts. Just please make sure if you're booking in, you specify Dr. Saira Sokwala, because there's another Sokwala at the Aga Khan University where I work, and you specify that it's the endocrine unit, and I'd be willing to help you out in any way possible. So thank you very much. Thank you so much.
Okay, thank you very much, and especially Karen and Sokwala, who stepped in very last minute. Kingi, thank you for being there from the beginning. Thank you so much. This was beautiful, and our audience, thank you. If you want to rewatch it, it's gonna be on the YouTube page. And if you want any other conversation around medical topics, I do this, by the way. It's just that I think people really wanted the menopause one. Tomorrow, we actually have a parenting one. You can join us. However you got this link, you can always get it. The parenting one is my other dream team, trust me. So join us tomorrow at the same time for that. But asanteni sana. You are my dream team. Thank you. And you can leave at your own pleasure instead of me just ending it unceremoniously.
Thank you so much, Posa. Good night or good morning.
Good night, Kenyans, by the way. Good night. If you want to unmute and say Asante, I don't mind.
For tomorrow parenting,
yes,
the same. For tomorrow parenting, we are using the same
link.
Password.
No. Oh, no, let me share the parenting one. Just give me a few seconds.
Okay.
Yeah.